Good morning. I would like to start by thanking the organizers of the IWCLL for selecting our abstract for an oral poster presentation. This morning I will be sharing our work on Pneumocystis jirovecii pneumonia, an invasive fungal infection, incidence and institutional prophylaxis practices in CLL patients treated with BTK inhibitors. I have no disclosures, and co-authors' disclosures are listed here. We know that CLL patients treated with fludarabine have an increased risk of Pneumocystis jirovecii pneumonia, or PJP. As such, at many institutions, it is routinely recommended that patients receiving fludarabine-containing chemotherapy regimens are prescribed PJP prophylaxis. With the development and use of oral BTK inhibitors, there has been growing attention to the increased concern of a potentially increased risk of PJP and other invasive fungal infections, or IFIs, in CLL patients on these therapies. Previous studies have looked at PJP, and there is a growing body of literature with not only case reports, but also case series of IFIs in ibrutinib-treated patients. These studies report varying prevalences, however, and less has been published regarding prophylaxis. At present, there are no international consensus guidelines regarding the use of antimicrobial prophylaxis in CLL patients treated with BTK inhibitors, and prophylaxis practices vary widely amongst clinicians across countries and institutions. To help further inform this discussion, we sought to determine the frequency of opportunistic infections in CLL patients at our institution who were treated with BTK inhibitors and to assess the impact of prophylaxis on reducing the risk of PJP. We performed a retrospective IRB-approved chart review of CLL patients treated with BTK inhibitors at Dana-Farber Cancer Institute and Brigham and Women's Hospital. Patients were included if they had received ibrutinib, acalabrutinib, or ibrutinib as part of a combination therapy regimen. Duration of treatment was required to be at least 30 days, and the timeframe of our study was from January 1st, 2010 until February 1st of this year. This table summarizes the characteristics of our study population, which included 212 patients in total. 120 of these patients received single-agent ibrutinib, 21 received single-agent acalabrutinib, and 57 were part of a clinical trial investigating frontline ibrutinib and FCR, and 14 patients were part of a clinical trial investigating the combination of ibrutinib and umbralisib in relapse refractory disease. The median age at initiation of BTK inhibitor therapy was 64.8 years. And for the sake of time, I will move on to this table where I will highlight that the duration of BTK inhibitor therapy overall was just under 2 years at 23.2 months. We found that overall, 59% of patients were on PJP prophylaxis. Within the BTK inhibitor monotherapy group, 40% were on prophylaxis. And in those on the combination therapy as part of clinical trials, actually 100% of patients were prescribed prophylaxis as part of the trial requirements. 74 of the patients on prophylaxis received trimethoprim sulfamethoxazole, and 26% were prescribed atovaquone. Out of the 212 patients we studied, again with a median BTK inhibitor exposure of 23.2 months, there were 3 cases of PJP. 2 cases occurred in our single-agent ibrutinib cohort. 1 patient was previously untreated, and 1 patient had relapse refractory disease. Neither of these patients were on prophylaxis. We additionally had 1 case of PJP in the frontline ibrutinib and FCR trial cohort, and this patient had been prescribed prophylaxis as part of the trial, but unfortunately self-discontinued her medication 2 months prior to infection. There were no cases in the single-agent acalabrutinib cohort and none in the ibrutinib and umbralisib cohort. The overall prevalence of PJP in patients not on prophylaxis was 3.4%. There were no cases of PJP in patients on prophylaxis, and the incidence rate in patients not on prophylaxis was 1.9 per 100 person years, with the number needed to treat to prevent 1 case of PJP calculated to be 42 patients. With regard to other invasive fungal infections, we had 3 additional cases of proven or probable IFIs. There was 1 case of pulmonary histoplasmosis in a patient on the ibrutinib plus FCR trial, and 2 cases of aspergillosis, 1 pulmonary and 1 brain abscess in patients on the ibrutinib and umbralisib trial. The overall prevalence of aspergillosis or histoplasmosis in our entire cohort was 1.4%. And notably, there were no cases of other IFIs in the single-agent cohort, but the prevalence in ibrutinib combination therapy patients was 4.2%. In conclusion, first we found that there were quite mixed PJP prophylaxis practices amongst clinicians, even within our own institution. Second, we found overall a low PJP prevalence of 3.4% in patients not receiving PJP prophylaxis. Notably, in consultation with our infectious disease colleagues, this falls below a commonly accepted threshold of 5%, above which routine prophylaxis becomes recommended. Third, we found that PJP prophylaxis was successful in preventing PJP in CLL patients on BTK inhibitors. And overall, our data suggests that routine PJP or IFI prophylaxis in patients receiving BTK inhibitors may not be needed, though this is definitely an area that requires further study, ideally with a prospective trial with a larger sample size and multi-institutional to support the development of consensus guidelines on this issue. I would like to end by acknowledging first and foremost my research mentor, Dr. Davids. I'd also like to acknowledge the database and administrative support at Dana-Farber, our infectious disease colleagues, my internal medicine residency program at the Brigham and Women's Hospital, and I'm also grateful for the Young Investigator Travel Award generously funded by IWCLL and the CLL Global Research Foundation. Thank you.